Good afternoon, everyone. This is Diana Arias with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Motivational Interviewing, Clinical Updates Within Substance Abuse Treatment. In order to treat substance use problems, clinicians must understand motivational interviewing, an evidence-based approach known to be effective with individuals who use. This webinar will focus on updates from from MI2 to MI3 and how to implement techniques within clinical practice. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it's not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Dr. Tara DeWitt, a clinical psychologist and a member of the Motivational Interviewing Network of Trainers. Once again, thank you for joining us, and I will now pass it to Tara to get us started.
Good afternoon, everyone. Thank you, Diana, for the introduction. So like Diana was saying, my name is Tara DeWitt. I'm a member of the Motivational Interviewing Network of Trainers. I work for a large national healthcare network, and I've been doing MI training probably since 2012, 2013, and it's really kind of one of my favorite parts of my job. So happy to be here today talking about motivational interviewing within substance abuse and kind of the changes between MI2 to MI3 as well. So we're going to kind of talk about the updates within MI3 and really kind of go over and appreciate the spirit of motivational interviewing, kind of focusing on including awareness of equipoise and compassion, which are two big additions and changes within MI3, and kind of expanding our MI toolkit to more readily navigate discord and bring forward change, talk, and ambivalence. So my sense is that a lot of people on the call have a pretty good understanding, have kind of been doing some work in motivational interviewing already. So I really kind of want to tailor things to get the changes within MI3 and kind of bring in some clinical vignettes and keep it as, you know, as clinically informed and realistic and kind of engaged as possible. So just kind of a little quote from Henry David Thoreau, thinking about things do not change, we change, right? So kind of people, places, and things, right? There's always these things in our environment that might elicit the desire to, specifically when we think about substance abuse, to use, right? And so how do we kind of navigate that? How can we kind of work with our treatment team, kind of as we think about our patient, kind of work within themselves to evoke change and to kind of move in the direction that they want to move in, which is usually, especially when we think about MI and Rogerian-centered therapy, right? Really kind of wanting to move in the direction of light and having things feel better in their lives. So our technical definition is MI is a collaborative, goal-oriented style of communication with particular attention to the language of change. So we think about there kind of being one active ingredient within MI, it would really be our change talk, right? Kind of evoking and bringing forward ambivalence, bring forward change in the direction of moving towards harm reduction or abstinence, or kind of in the direction of the target behavior, you know, thinking about substance use, kind of cutting down on using substances. It is designed to strengthen personal motivations for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion, right? And that's a really kind of new component. I mean, I think it's always been there, but we're really kind of defining it and semantically talking about it in a different way in MI3 kind of bring in the element of compassion, that whatever work we're doing, we need to be really clear that this is in our patient's best interest. And we'll kind of talk about that a little bit more as we go along. So just kind of thinking about the spirit of MI, right? Kind of how to move towards the sun, how to kind of best work together, right? Especially when it's normal, if we think about just looking at this image with kind of bucking horses, right? That it's normal whenever our patients, or we think about our own experience or faced with a change, that it's normal to kind of buck a little bit, and how to kind of hold that and come alongside and support that. I have it in the references at the end of the slide deck, but really if folks haven't seen it, a great is available on YouTube, the Join Up video with Monty Roberts. It's a really just nice visual illustration working with a horse of the spirit of MI. So we kind of took a look about and kind of talk and kind of get into like, well, what's in the spirit of MI, right? So Bill Miller and Stephen Rolnick will really kind of talk about these 4 different elements: collaboration, acceptance, evocation, and again, really very much bringing in compassion, right? Kind of this coming from, you know, seeing some stuff that was going on more maybe within like a sales community, or kind of like some different disciplines, using some of the tools to facilitate change that maybe wasn't always in a person's best interest. So really, you know, the MI community and specifically Bill Miller and Stephen Rolnick really working very closely and saying, well, how, you know, MI is different, right? Because we're really clear that we're working in our patient's best interest. And so how do we want to semantically define that? And within the spirit, they kind of define that as compassion, right? So again, we're very clear that our target behavior, the goal that we're working towards, is going to make whoever we're working with, the patient's life, hopefully better. So we think about acceptance, really supporting absolute worth, one's own autonomy, right? And if we look about some of our coding instruments that have kind of developed with, you know, with the change from MI3, the MIghty tool, which is a primary coding instrument, moving from the 3.1 to the 4.2, really kind of says that we need to have some specific illustration, reinforcement of our patient's own autonomy, that the provider needs to explicitly say that in order for this to kind of be like a true MI session. So something along the lines of, you know yourself best, you're really in charge of this change that you want to make, right? Whatever, kind of based upon what the patient's saying, that's really supporting and reflecting their own autonomy. Accurate empathy, kind of thinking about the difference between empathy and sympathy, right? Kind of empathy is almost making ourselves a little bit more vulnerable, kind of getting in there, getting down on our knees. Brene Brown has some great YouTube clips talking about the difference between sympathy and empathy, and working our best to kind of get it right. And if it's done within an atmosphere of compassion and engagement, if we're not getting it right, usually our patient's gonna tell us, and it's kind of like this hypothesis testing that guides the conversation forward in the direction of change. And affirming, right, which is very different than cheerleading, right? Really kind of coming alongside, utilizing our statements, kind of complexifying our reflections to affirm someone's efforts to make this change. I think sometimes a really good way to use affirmations is when someone's tried to make a change and they're sober for a period of time, and then something happens and they start to use again, and to kind of affirm that attempt, right? Because sometimes it can be very much seen as a failure, to affirm that they learned a lot from this experience, they learned a lot from themselves, and how can we best work to bring that forward into this conversation about making change again. Right, and just kind of thinking about autonomy and support, right? The overt recognition of the client's right and capacity for self-direction. So kind of really coming from, Rogerian client-centered therapy that everyone wants to kind of move towards the light and affirming and supporting that. Right, so we can just kind of slow down for a little bit and think about some assumptions that could be, am I inconsistent? And some that could be, am I consistent? Right, so I am the expert on why and how patients should change. And kind of shifting that to, I have some expertise and patients are the experts on themselves, really supporting their own autonomy. I collect information about problems, and maybe sometimes you do need to, right, during an intake. And yet we could also kind of think about, is there a way to get that information in a way, may not specifically be an MI session, but in a way that's more consistent with the spirit of MI. Right, I find out what info the patient wants and needs, right? So we can kind of tailor information that may be helpful to provide based upon what they already know, what they think might work for them. I correct gaps in knowledge versus I match info to patient needs and strengths. So MI has a really nice acronym around that, kind of called EPE, elicit, provide, elicit, right? So asking them what they know, asking permission to provide some information, and then kind of following up with what they think about that. I just need to tell them clearly what to do, right? So, and we think about kind of, infomercials and, blasting people with information really doesn't facilitate change. That's what a lot of the research shows and supports, but I imagine people can kind of think about their own experience, and that hasn't been so helpful for them. So thinking about advice that champions patient needs and autonomy can be helpful, right? So again, really, it's like unsolicited advice is the junk mail of life, really kind of tailoring information to, where the patient's at. And we think about evocation, right? Kind of really drawing out and bringing forward that change talk, right? That's what kind of makes MI, right? That's the active ingredient. It's a guided intervention. Kind of everything that we're doing is in the patient's best interest and is also geared in the direction of change, right? When we know that that change is in an element of compassion and is in the client or patient's best interest. So I just wanted to kind of consider two clinical vignettes for a little bit, right? I was recently had the opportunity to shadow and assist the training that Stephen Rolnick was actually doing in the New York City area. And, he was really talking about like rose-colored glasses, right? And frequently when we kind of need to know the DSM and to kind of think diagnoses and how to kind of best help people and what's going on for them. And yet sometimes in that, like our rose-colored glasses get lost, right? Kind of a sense of being able to see someone's strengths, right? And that can kind of help us to feel very different in session or working with a client or working with a patient, and it can have our patient feeling very different, right? Especially when we think about components of affirmation and autonomy, right? So just kind of, just taking these two different case examples, right? You kind of just come in, to work, you're going through like your roster of who you're going to see today, and this is your 11 a.m. client, right? So a 61-year-old African-American male with a history of incarceration for petty larceny and selling drugs is currently using cocaine. He was referred to a vocational program to receive his CDL license, but was asked to leave following a dispute with his instructor. Patient is currently supporting himself on disability payments and utilizing cocaine on a regular basis. So just kind of like check in with your gut for a second, right? How are you kind of feeling about seeing this person this morning? I should have made it your 1 p.m. because this is a 12 o'clock webinar, but someone kind of that you're expecting to see soon. And then this clinical vignette. A 61-year-old African-American male with an extensive history of childhood physical and emotional abuse sustained at the hands of his father. Patient was recently racially targeted at a local convenience store and served 2 years and 8 months in prison for reportedly stealing candy. Patient reports that he wants to receive vocational training so he can get work. Patient is currently using cocaine and supporting himself on disability. So just kind of thinking for a moment, right? Which client are you more looking forward to seeing? Which client do you feel more empathy for? And which client do you anticipate a better treatment outcome? Right, and just think kind of then hold, how these different components might affect the opening up of session, engagement, empathy, right? Especially thinking those as a really critical component of effective treatment as well. So this here is kind of tying back into the sense of compassion. Right, so compassion requires knowing when to maintain neutrality. Right, so MI3 is really kind of talking about this element of equipoise. Right, so if we're not clear that a specific behavior change, or kind of from an MI concept is kind of thinking about a target behavior, right, for here purposes of reducing substance use, right, we can be really clear that that's in our patient or client's best interest. But there may be times where it's not as clear, right? Some examples that we can kind of think about are maybe having kids or not having kids, right? Donating an organ. That might be times where we're kind of utilizing the spirit of MI, and yet we're not going to kind of guide in the direction of a specific outcome because we're not clear that that's in the patient's best interest. Right, another difference between MI2 and MI3 is kind of it's moved the tent poles out a little bit in terms of a target behavior. So a target behavior could be, being more forgiving. Like it can be a little bit more abstract. And yet again, if it's still clear that this is in the client's best interest, that we can do MI, right, and kind of hold and hold the spirit of compassion in that. Right, so this is going into the 4 processes of MI, right? They kind of, the arrows all go up, right? But we also want to kind of hold that if at any point we feel like we're disengaging, we're getting discord, something's happening in the relational component, we're just going to kind of slow down and back up, right? So first kind of thinking about the relational foundation of engaging, right? And then once we've kind of maintained that, we can move into focusing or kind of specifically kind of tuning into and thinking about, well, what's the target behavior, right? What do we kind of want to focus in on together, right? Someone who's using substances, they, it can even be possible if it feels like there's a lot going on. A tool that I like to use, I kind of call it like the bubble worksheet, right? So it's just like this piece of paper with like lots of bubbles drawn, and it's kind of like agenda mapping. So, right, so you can kind of talk about, well, things feel really overwhelming right now. What do you feel like is kind of getting in the way of establishing your housing, right? And so it might be anger, it might be their substance use, it might be a whole different thing, but you can kind of slow it down, put different things in a collaborative way in those different bubbles, and then have a conversation about where would you like to start, right? And it's from there that we kind of start to evoke, right? And this is like our true transition into MI, right? You're really committed to making this change. How would things look different if you were able to stop using cocaine and hold down a job. Right, and then once we start to kind of hear, once we're really not getting any discord, maybe we start to hear some envisioning or some kind of asking questions about, well, how do your other patients do it, or how do your other clients do it? Right, that might be a time where we kind of want to dip our toe into the planning waters as well. Right, and again, at any point, if we're losing that engagement, just want to like slow down, back up, maybe even apologize, right? Well, I'm sorry, I feel like I got out ahead of you here, right? Is it okay if we kind of slow down, right? So we kind of really just conceptualize this, right? Engaging the process of establishing a helpful connection and working relationship. Focusing is a process by which we develop and maintain a specific direction and the conversation about change. And again, we're really clear that that change is in the client's best interest. Evoking involves eliciting the client's own motivations about change and lies at the heart of motivational interviewing, right? And sometimes it's like, well, what do we do if we're not getting change talk, right? So we can think about, well, we can just ask for it, right? We can kind of use our open-ended questions to kind of ask some questions of what would this change look like? Maybe this is a great place if we're a little bit stuck to use like our confidence and motivation rulers, right? On a scale of 0 to 10, how confident are you that you can make this change, right? And then we kind of want to follow up with, well, you're at a 6. Why are you at a 6 and not a 3, right? You're kind of pretty far up there. And what would help you get to a 9, right? So it's really like through the querying of the rulers that we can facilitate more change talk, right? And that might also be a good sense to kind of get a sense of, well, someone's really high on motivation and they're kind of low on confidence. We might actually want to like hold on to the spirit of MI, but kind of step out of that evoking, and they may need some more specific skills, right? So I think that's also a good gauge of kind of what someone needs in order to kind of move forward and make this change, right? And then planning encompassing both developing a commitment to change and formulating a concrete plan of action, right? And again, we can kind of dip our toes into the planning waters, and then if we feel like we start to, right, sometimes when we move into planning or we move a little bit too quickly into planning, this can be a place where discord kind of picks back up. So just kind of being really mindful of that and holding that, we can back up if needed too. And I would also say that if you really, to also not be, just to be aware, but not also be overly concerned about moving into planning too soon, right? What we also don't want to do is when someone's really clearly saying that they want to make this change, we don't want to keep evoking, right? So we always kind of want to be like really mindful of where our client or where our patient's at. So we're kind of thinking about the foundational skills of MI, right? Again, MI likes lots of acronyms. So we have our ORs here, our open-ended questions, our affirmations, our reflections, and our summaries. And if we just kind of think for a moment about some of like our coding tools within MI, that a lot of them are kind of looking at our affirmations and reflections and summaries as they're all kind of under the guise of like the larger umbrella of reflections. They're just kind of different types of reflections. And we want to kind of think about using a 2-to-1 ratio of reflections to questions, right? Because what reflections help to do is to kind of develop like this metacognitive process for getting our client or getting our patient to think about their own change process, right? They're not just responding to our questions. When we make a statement that's in the direction of change, that's connected to what our client has just said, it allows them to kind of start to envision, to start to kind of think and hold what this change might look like. And so sometimes the most important thing of MI may not be as much, it is what we hear. It is what we hear from our client. And also there might be a lot more going on behind the scenes in their own mind, in their own head, that actually may be more predictive of the change than we actually hear. And so when we kind of are giving or holding and kind of putting out there more reflections than questions, it facilitates that happening a little bit more, that more metacognitive process. Right, and we also kind of want to think about, sometimes we need to ask closed questions, right, to kind of gather information, and also if there's a way to kind of shift that into an open-ended questions, right, and sometimes you can even challenge yourself to think about, with that open-ended question, is there even a way to make it a reflection, right, but kind of thinking about our open-ended questions allow for more than just a yes or a no response. So frequently the prefix is really important, right, so shifting from can you tell me more about that to tell me more about that, right? Again, you might not get a yes or no response from the client or from the patient back, and yet it just kind of sets the stage for like a more perhaps elaborate conversation, kind of just where they're at. Right, so we can really use our open-ended questions to facilitate understanding, to kind of get a better picture of where someone's at, of what's going on, of setting the agenda of specifically what they'd like to focus on, and kind of eliciting some more change talk, right? Asking for that change talk if we're not getting it, as long as we have, that first process of MI and kind of are keeping that engagement. Affirmation, really kind of connected to the spirit of MI, right? Recognition of efforts, recognition of strengths, tied directly to the change that your client or patient's looking to make. Reflections, understanding, empathizing, eliciting more, reinforcing change talk that you're already hearing, right? And kind of perhaps challenging oneself to deepen those reflections, to amplify them, to complexify them, so they're really, and I think it's kind of one of the harder skills of MI, is to really kind of get in there with those reflections. And sometimes it's even harder to make those reflections shorter and really kind of reinforce and highlight the change that our client or our patient's saying already. In summary, really, letting them know that they're being heard, right? That you're understanding them, kind of keeping that engagement, that accurate empathy. It's also an opportunity to reinforce the change talk, and can even be a really nice tool to use to transition to planning as well. So we think that the spirit of MI is to really appreciate ambivalence, right? It's like ambivalence is like almost the starter to our active ingredient of change talk, right? So it's kind of bringing forward this discrepancy of where they're at and where they want to go that can bring forward the ambivalence. There's a really nice tool called the Value Card Store. It's public domain. You can Google it. Can print out as a nice PDF, and it can be a really nice activity to use with someone, especially maybe clients or participants who would, patients who would benefit from maybe perhaps a more concrete tool, right? It's just an opportunity to talk about their values, to have them pick out their values, and then use that to guide a conversation about perhaps the discrepancy between where they're at and where their values are, and what will kind of help them move in that direction. So we kind of just think about the tenets of ambivalence, right? If you argue for one side, an ambivalent person is likely to defend the other side, right? We can all kind of think about this in our own personal experience, right? You're talking to a friend and you're dating someone and you're complaining about them, things aren't going so well, and they start to say, well, you should really leave this person, they're no good for you, right? Kind of the somewhat natural reaction is to say, well, they're not that bad, they gave me a gift last week and they've gotten better at texting me back, right? So, right, when we take one stance, it leaves our clients or patients kind of arguing for the other stance. And as a person defends the status quo, the likelihood of change decreases. Right, so again, we want to focus on eliciting change talk, right, which is really MI defined as a self-expressed language that is an argument for change, right? So if our patients, if our clients, if they're, right, MI2 talked about wrestling, right? But if they're not in discord with us, right, it kind of leaves them perhaps in discord or wrestling with themselves in where they're at and where they'd like to be, right? So if we come alongside and are affirming and supporting and asking open-ended questions and reflecting back their experience, it provides an opportunity for them to bring forward more of their own internal ambivalence. So it's not that we're like handing them the ambivalence, we're just providing an environment and kind of reflecting back what they're already saying to bring that more to the forefront. If we kind of think about the image of evocation and kind of bringing, you know, the water out of the well, the water's already there, we're just kind of facilitating it coming more to the surface. So really kind of we think about change talk as being very specific to motivational interviewing, right? No kind of evidence-based psychotherapy talks about kind of change talk in this way. Again, the self-expressed speech that favors movement in the direction of change. And it's the opposite of change as sustained talk, right, which the MI defines as speech that favors things staying the same or status quo. And some new research is kind of pointing to that when change talk is happening more at the end of a session or end of an interaction, that also facilitates the more likelihood of that change happening. So the change talk is really important, and also what's kind of coming to pass is showing that it might also be important where it happens in the interaction too, right? And we can kind of think about when we leave an interaction with someone, and that's kind of what we hold on to. What happens at the end is kind of what we come back to. And so when we're ending with change talk, it's more likely to kind of have more energy or have more volition on its own after that interaction. Right, and so we kind of define change talk as expressing one's desires, abilities, reasons, and needs to change, conveying optimism about making change and the benefits of succeeding. May also state a willingness or intention to change. Right, so again, a really great acronym that's kind of been redefined a little bit within MI3. So we have our darn cat, our desire, ability, reasons, and need to make the change, and that's kind of our preparatory change talk, right? I want to get clean. I think I can get clean. I'm going to lose my job if I don't get clean. I need to get clean for my family, so my probation officer gets off my back. And then we can think about our activating change talk, our commitment, our activating, our taking steps. So, you know, I think in an interaction, in a session, it's not necessarily so essential to know what type of change talk we're hearing, as long as we're just responding to it. But I think when we're kind of slowing down and kind of getting into more like the nuts and bolts of MI, it is helpful to kind of hold that there are different types of change talk, because I think as we kind of develop our MI skills, that can help kind of strengthen and complexify our reflections as well. So if we think about our commitment language, I'm going to make an appointment to go see my counselor. I'm willing to get on the bus to go to Voc Rehab. I've already called and made that appointment, right? So you can kind of hear how they're all change talk, but they're just a little bit different, right? Between the preparatory, kind of leading up to, and then like the activating, the things that they're committing and they have already done. So kind of what do we do when we hear change talk? Right, again, another really great acronym, right, EARS. So elaborate, right, really kind of asking this nice open-ended question of, tell me more, right, seeking details. getting different examples, establishing meaning and connecting with perhaps their values and goals, right? Affirming their experience, right? Reflecting the change that you're hearing to deepen that change, to kind of deepen that commitment, to solidify it more. And so you can kind of get more change talk and perhaps move in the direction of plan as well. And then summarizing, right? So change talk provides the flowers in the bouquet, right? So you're kind of, you know, maybe this is done at the end of an interaction. I also think it's really nice to kind of do at different points during the course of an interaction or a session, right? So you're kind of offering some mini summaries where you're kind of not leaving it all to the very, very end. You're kind of like reinforcing as one goes. And also that could be a nice opportunity to take some steps into the planning waters, so to speak. So we kind of want to do that in a way that we maybe have a little bit more time to follow up on and to kind of ask the follow-up question of where does that lead you to. Right, so again, if we kind of aren't hearing change talk, right, really feeling like we can ask for it. Right, utilizing our importance and competence rulers, our readiness rulers, right, at a scale of 0 to 10, how ready are you to make this change, right? Why why are you at a 6 and not a 3? What would help you to get you up to a 9, right? That you know, these aren't definitive numbers, right? These aren't numbers that we necessarily want to put in a client or patient's chart. It's really a tool that's designed to elicit more change talk. So we want to kind of be really cognizant, be really aware of not just asking the ruler question, but following up, right? It's in the follow-up that's where we promote the ambivalence and kind of get more change talk, right? Querying extremes, right? Maybe kind of offering, if you have a good engagement with someone, some amplified reflections, right? Again, this is always within your larger clinical wheelhouse, but thinking about there's nothing you can do here to make a change. Or, you know, what would things be like if you continue down this path, right? As long as that's not kind of seen as confrontational, right? But it's kind of a really connected and empathic stance. Hypothetical questions, right? What would things look like if you made this change? Right? Maybe similar to kind of looking forward. You know, you stop using cocaine. You know, how do you see things being in a month, 3 months, 6 months? Right? You're really clear that family and getting a job is important to you. How do you see that being connected to your cocaine use? Right? And again, kind of you're using the value sorting part. That's a really great way to know their values or their goals, or maybe you kind of know it just because you've been talking about it and bringing them forward and reflecting and asking some questions about it to elicit more change talk as well. So I think it's really important, I said so already, but to not shy away from moving into planning, right? You know, there's been some conversations that folks are, you know, really so mindful and so cognizant of getting change talk that sometimes there's kind of this missing that of hearing that someone's ready to move into planning, right? That we kind of stay in the querying and the reflecting, and then actually kind of we get this discord because we're no longer kind of meeting our patient, our client's needs because they're maybe actually ready to get some more information or to take those next steps. So really kind of being mindful and aware that we can step into that when we're hearing that, right? So some good signs of that is that we're hearing increased change talk, decreased sustained talk and discord, right? So no longer are we hearing, you know, all the reasons why it was so hard for someone to get to your office or to meet with you, you know, or all the reasons reasons why their alcohol use isn't a big deal, right? That's kind of really diminished, and now we're hearing more change talk. Kind of less discussion of the problems, because thinking about nonverbal indicators like size, tears, more questions about change, right? How have other people gone about this, right? What would you recommend, right? And we can kind of think about, well, when we're asked for kind of personal recommendations, how to kind of also hold and support their autonomy in that, right? Kind of maybe saying back, well, I have a lot of ideas about that. I'm really happy to talk about it. It also sounds like you know a lot about yourself. You've had a lot of experiences stopping for a period of time. And so what do you think at this moment might work best for you? Right, and so then it's kind of like tailoring the information to what they know about themselves. So I think it's really important, especially when moving into planning, to really support someone's autonomy. And kind of build in the fact that there might be flips and setbacks, right, and really normalize that as well. Right, someone might be starting to envision what this change would look like, right, how they might have more money in their pocket. They might be less worried about their housing, all the different components of how this change would affect their life. Right, you might even kind of hear them start to talk about taking steps, right? You know, I think I could call my sponsor or reconnect in that meeting. You know, I've looked up the schedule online and I've kind of figured out what day might work best for me. So again, we can just kind of test that water, right? And if we get out too far ahead, it's okay to kind of back up. And we also don't want to avoid testing the water for concern that we might get out too far ahead, right? It's always a balance, and as long as we're kind of keeping that engagement, you know, we can move forward and we can also back up. Right, so just kind of offering a bouquet of change talk, right? Kind of offering this nice summary, and then kind of testing the waters of moving into planning. Although there are things that worry you about going to treatment for your substance abuse, you're recognizing that it's causing problems at obtaining a job. Financial independence is important to you, as well as the opportunity to learn new skills. And you're not sure how to manage the cravings on your own. Where does this leave you? Right, so you're kind of bringing forward all that change talk that you've already heard, and then opening up with this nice open-ended question that's affirming and connected to them, and to get a sense of where they're at right now, right, to kind of start testing those planning waters. Right, so, sorry, there's an extra S on resistance there. So really kind of change from MI2 to MI3, right? We used to talk about kind of rolling with resistance, right? You know, kind of dancing instead of wrestling, right? And so MI3 is kind of defined it just a little bit more specifically and kind of got in a little bit more detail, kind of thinking about we're dancing with discord, right? And really kind of even breaking down and defining what's discord, right? So we kind of to deconstruct resistance for a little bit. So thinking about resistance within MI2, and now MI3 is kind of holding that sustained talk and discord, right? So discord being within the interpersonal relationship in the room or wherever you're engaging with your clients, that they're kind of, you know, fighting, arguing with us, as opposed to kind of having the opportunity to sit with themselves and with their own ambivalence. And frequently when that's happening, we're also hearing more sustained talk, right? All these reasons why this change isn't possible. Right, so thinking a lot about discord, it's about us, right? It's a component of a relationship, symptom of a relationship, or disengagement of a relationship. And thinking about nonverbal and verbal cues from it, right? Someone could be slumping in their chair, becoming more quiet, looking out the window, right? Or verbally, we could be hearing more sustained talk. And frequently, how we are responding to sustained talk is often the culprit when we're kind of getting into the writing reflex, right? I think kind of coming from helping professions, we all have this desire to help, to fix, to make things right. And sometimes when we move a little bit too quickly about that or haven't kind of nourished the relationship or kind of evoke change talk, that can actually promote more sustained talk, kind of thinking about coming in there with that unsolicited advice or arguing for the other side too. So signs of discord can be defending, squaring off, interrupting, disengagement, or arguing. So again, certainly verbal and nonverbal cues as well. So how can we dance with discord, right? Just kind of thinking for a moment about specific strategies, right? So really reflecting, slowing down, coming alongside, emphasizing autonomy, apologizing, affirming their own experience. You know, I think if you also kind of take a look at the Join Up video, right, with Monty Roberts, and right, there's times where it's this illustration of putting a saddle on a horse. And so there are times where the horse starts to buck, and he talks about that I'm not even going to call that bucking, right? Like that makes perfect sense whenever we're trying something new. That makes perfect sense, and kind of just giving like the horse a little bit more room to figure that out, right? So if we're kind of moving into planning and someone starts to really think about doing, you know, cutting down, going to meetings, right, and all of a sudden we hear more sustained talk, or they start to get quiet, or we feel like there's this disengagement, right? How to also really normalize that, right? Like this is really hard. This is a big change. Maybe it feels like we're moving too fast, right? It's okay. We can kind of back up a little bit, right? So I think also sometimes holding that discord or sustained talk can be part of the process, and it's kind of what we do with it and how we respond to it that is going to kind of predict, you know, how much change talk we get after that. And so I've just, you know, that's really kind of like a quick overview of motivational interviewing, of the changes between MI2 to MI3. So here I've just included, this is just a really snippet of resources. So I talked about Brene Brown. I'm sorry, she has a little accent over the E there that's not on the slide. But really nice if you Google like sympathy versus empathy on YouTube, just a really nice, cute video on that. The Rounder with Dr. Terry Moyers, who's very big within the MI and MINC community. The Rounders, I think it's back in the 80s. It's still just a really nice illustration of sustained talk and evoking and dancing with discord. And then the Join Up video with Monty Roberts as well. If anyone was interested in looking at one of like there's a couple of different coding tools, but one of the kind of most widely used is the Mighty 4.2. It's available on the CASA website. And there's the link there, and I also included the link for the value card sort as well. So Diana, that's all I have. Should I can turn it back over to you for some Q&A?
Sure. Thank you so much, Sarah. Certainly do appreciate your presentation here, and we do have a couple of questions. So first off, let's see, I do want to remind everyone that you can still submit your questions to the chat box. So one of our first questions here is, can you repeat the name of the tool? And you might have just listed it on the resources, but during the ambivalence piece, it seems that you mentioned a resource that was easily available via Google. Was that one of the ones that you just mentioned?
Absolutely. Not to promote Google, but it's the value card sort. So you can search for it, and the link is also available. It's from the It's public domain, so the link is also available on the resource slide as well.
Okay, and I'm sorry, can you give me the name again, the value card score?
The value card sort.
Okay, great, thank you.
You're welcome.
So let's see, our next question, can you speak to working with ambivalence connected to heroin use when the use is so risky? For example, multiple overdoses, episodes of Narcan, peer overdose deaths, episodes of use, using a lot, etc. What's the next, when the next use could potentially equal death?
Yeah, I think that's really tricky, right? Because we always want to work in our, in our client and our patient's best interest. And so, is harm reduction enough at that point? And I also think there's a ways that maybe that can be part of the conversation, right? So you've had a lot of close calls. And if you want, we can certainly kind of, talk about cutting down or kind of some different strategies. And I'm also wondering what your thoughts are. Maybe you feel like you need more right now, right? Maybe I'm just kind of stepping out of character for a second, but like, is that a detox, right? Maybe that conversation becomes, having an engaged conversation that's connected and collaborative about a higher level of care.
Great, thank you. Our next question, similar along those lines, is there anything that should be done differently for someone who is using K2? There's such severe side effects and high risk for overdose. It seems sometimes there isn't much time to dance with this chord because of the unknown additives to K2.
Right, and so it may be like a similar conversation like the heroin question as well, right? Maybe using like a little bit, again, keeping that engagement, but using a little bit of like that provide illicit. Is it okay if I kind of give you some information about the risk here? What do you know about the risk, right? And then kind of see what they say. Is it okay if I follow up with some more information? And kind of given that, what do you feel like you want to do here in terms of treatment options? I think that, right, this is sometimes where like we have to be mindful of our writing reflex, the risk, right, like our professional oath, our ethics to help, right, to not have someone leaving and being in danger, and balancing all of that with sometimes when we move too quickly, that like the dangerous outcome is actually more likely to occur, right? It feels the opposite in the moment. I think it's so tricky, and so like, is there room to plant the seeds of ambivalence, right? Or in that moment, does it feel like it's a little bit more of a tailored and structured conversation about, again, also still supporting their autonomy, right? It's always their choice, and perhaps there might need to be kind of like some more tools or some more resources, so it feels like there's kind of more containment around the behavior.
Right, great, thank you. And I know it's certainly difficult when, that there is such either high use or high just side effects per se, right? And the next one can certainly be someone's life. So moving on to our next question, let's see. I facilitate a drug education class and was wondering, how do you try to create a change with a client with a substance such as marijuana, because it is so widely seen as to not be a drug and should be legalized?
Yep. And that'll frequently come up, right, in terms of, clients will talk about, well, especially if like they're mandated for treatment or something's going on, right, they'll talk about, well, if I was in a different state, if I was in a different area, like this wouldn't even be an issue, right? And so how we cannot kind of wrestle or be in conflict with the system or the state or where we're working, and really have kind of a conversation about like reflecting that back, right? So if you were in a different state, if you were in Colorado, you wouldn't be here, right? And since you are, is is there anything that you might want to talk about, or are there any downsides to marijuana that you see? Right, again, I think it is first to have, like, do they see this as a problem, right, and kind of opening up the ambivalence around that, and how not to, right, argue that even though it may be legal or legal in some areas, that it's still a drug, right? We can kind of come alongside, not necessarily, we don't have to necessarily agree, but we can kind of support what they're saying in their own experience. Then we can kind of elicit and evoke more change talk. Potentially, this may not be something, right, again, we're only doing MI with folks that are ambivalent. So they may not be ambivalent about making this change. And so we also kind of have to determine that.
Right, keep that aware and be conscious of that. All right. So I do see that we are almost up to time. So I did want to thank you, Tara, and thank you, everyone, for attending today's webinar. The slides will be up on our CTAG website within the next 3 to 4 days. But I certainly do invite you to join us for our upcoming events. If you have any other questions, please contact us at ctac.info@nyu.edu. And once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide us your feedback. On behalf of CTAC and our presenters, thank you for joining us today, and have a great rest of your day. Thank you.
Thank you.